We are excited to welcome a truly outstanding guest to the show, our friend, Dr. Rajan Kohli. Based right here in Dallas, Dr. Kohli is a board-certified family medicine physician with more than 20 years of experience in both traditional and integrative care. He previously served as the medical director and chief of medicine at White Rock Medical Center, and now leads his own practice, Lakewood Primary Care and Wellness. At his clinic, Dr. Kohli blends conventional medicine with functional and regenerative approaches, offering patients a truly personalized path to better health. He is also fellowship trained through the American Academy of Anti-Aging Medicine, bringing a forward-thinking, holistic mindset to every aspect of care. From chronic disease management to bioidentical hormone therapy, weight loss programs, and anti-aging treatments, Dr. Kohli is known for his dedication to whole-body wellness and his approachable, thoughtful style. Fluent in both English and Hindi, he's helping to redefine what compassionate, modern healthcare looks like. Let's jump in and explore some powerful health insights with Dr. Kohli.
Dr. Kohli, welcome to the show. We're honored to have you.
Thank you. You missed out. I'm also proficient in Punjabi.
Punjabi.
That's right.
All right.
Jeez, it's like a whole novel there. I want you to pat yourself on the back a little.
Yeah. All right.
But
so
thank you for the amazing introduction.
Yeah.
I didn't know all these good things about me.
That's right.
Did you research those?
We did thoroughly.
Excellent.
And so we want to kick things off and just let us know what drew you to healthcare and maybe your story in that regard.
Yeah, so I grew up in New Delhi, India. And my father is an attorney. My mom worked for the government. She's a very wise lady. When I was growing up, I wanted to be a lawyer. I wanted to join my dad's practice. And then in 11th grade, we switched schools. And I picked up, in India, you're supposed to pick up different majors in 11th grade. So I went into mechanical engineering. And in about a week, I knew I hated the class. I hated everyone in the class. And I wanted out. One of my good friends was in biology. So I kind of switched my major to biology. And then fast forward, me and him, we kind of studied together. And he came from a family of physicians. I had no physician in my family. And as we studied for the board exams and we got into med school, my passion for medicine increased tremendously every year. And after during the residency, and so rewind, I did my med school in Pune, which is near Mumbai in India, and then subsequently I came to the States. I did masters in public health and Kentucky, Bowling Green, and then I finished. After that, I got into residency in Pontiac, Michigan, and I was gonna live in Michigan forever, but then the economy in 2005 was pretty bad. I had a lot of family in Houston, so the thought was that I'll move to Houston and be close to family. But luck would have it, I visited Houston a few times, and I decided it was against my. It's something that it wasn't a place for me.
Right.
I just didn't want to be there. I chose East Texas. Yeah.
That must have been
And the reason being, it was a small hospital in the middle of nowhere, and I had the ability to practice medicine in a way that's very difficult to accomplish in a big city.
Got it.
I was working in the ER, the nursing home, the hospital, and the outpatient practice. So the growth in the clinical skills in the 3 years that I was there is probably comparable to the growth you would normally expect, if you were in a big city, maybe in 10 years, because you're basically it. If there's something terrible happens, there's one surgeon, there's the ER doctor, and there's one other guy.
Right.
And you're sort of the backstop to every situation. So that was, we're talking 2005 through 2008, mid-8. And then I was on call one day for the hospital. So I got called in, it was about 6 p.m. And, this was in Tyler. So I drove to work and I parked my car in the parking lot. I was crossing the road, there was a stop sign, and this one lady, she was not paying attention. She had a child, and she kind of hit me, and I heard a crack in my leg. So I saw the bone sticking out, and then I fell down. I was sort of losing consciousness, and then her rear tire went over the rest of my leg.
Oh my God.
It was a bad wreck. It wasn't pleasant. I called the hospital that I worked in, which was 10 yards away. I told them to come in, pick me up. And I'm outside with a broken leg. So they got me in. They got me. I remember, because this never happens. We never give narcotics for pain, but boy, that pain was bad. So I ended up taking almost 20 milligrams of morphine in the first hour. Just the pain was bad. The bone was sticking out. So they flew me out to Tyler. I had surgery overnight. Fortunately, the surgeon was fantastic. My mom came, my sister came, and I was sort of bedridden for 6 months. I kind of changed my perspective in life. I think you grow a sense of empathy a lot more when you're hurt, and there is tremendous growth in you as a person. You have a lot of time, after you watched your 100th show on the Netflix or everything else, you still have a lot of time to self-reflect about yourself and where you're going and whatnot. So there was a lot of that, and there's a lot of bitterness. There's a lot of hate. So you go through all sorts of emotions when stuff like that happens. But it shapes you as a person. It brings depth, when stuff like that happens, you can fold or you can rise up. And I think in life, people who are successful, and even the ones who are not successful, I think it's always a good idea to embrace that philosophy that, it's not who you, how successful you are, but when the chips are down, how do you get up and how do you respond to adversity?
Right.
So it shows character. It shows, so I'm not bragging about myself, but it was a journey. It wasn't, it just happened. And I decided that it was time to move to the city. I moved to Dallas, and this was end of 2008, early 2009.
How old were you?
I was 34, 33, 32, 33, something like that, yeah. So about 15 years. And then I was, back then the source of employment was Indeed, just like it is now.
Yeah.
So I was on
Coming
the
full circle
internet.
here.
Yeah. So I found this guy who was a hospitalist and medical director at Corsicana, and I interviewed with him on crutches.
Wow.
And he was instrumental in hiring me and being my mentor for the next decade, even until now. And he shaped my future career. He was a great guy and is a great guy. And every time, when I had my wedding, I spoke highly of him. And every time I have an opportunity to brag about him, I do.
Right.
So thanks, Chris, for being the mentor you are. So I worked in Corsicana, I lived in Dallas. It was a 60-mile one-way, and we'd have to drive most days of the month, back and forth. So I was driving quite a bit.
Right.
While I was doing that, simultaneously I started working in Baylor Waxahachie, which was, still in its infancy. It was a very small facility, and then the director, my boss over there, they really liked me and they wanted me to come full time on board. And it was a great opportunity. They gave me directorship, chief of medicine. So I embraced that. Then as the hospital grew, they went into different buildings. So we became part of the big Baylor system. Grew tremendously. I was with them for several more years. And then in 2017, 2018, right at the end, cusp, I found a good opportunity close to where I live, which was Waxahachie was a little bit of a drive. I live in Dallas, so I found a hospital close to me, which is White Rock Medical Center. It used to be called
what was it?
White Rock Medical Center.
Yeah,
So it's right on the lake.
Okay.
It used to be called Doctors Hospital and City Hospital. So I came on board with them as a hospitalist, and in 2 months they they offered me the position of medical director and chief of medicine, and I took that. While it was a great program. A year into the program, I decided that I want to venture into outpatient medicine simultaneously while I was working as a hospitalist. So slowly we opened a practice inside the hospital, which grew, and I hired a nurse practitioner who ran the outpatient front, and then, it was sort of a combined effort, me and her. And then I would do the inpatient side. And now the practice is thriving. We have another provider who just joined, and we offer different types of services. And I think Jason's going to get into it.
Well,
So that's the short of the long.
No, that's fantastic. You've had a lot of adversarial events growing up to get to where you are. I believe in India, specifically, there's like thousands of people that are trying to go the medicine route, and only a small fraction are selected, right?
Yeah.
Do you know the
so
stats?
I think the stats are, I believe every year there's about 200,000 to 300,000 or more who sit for the entrance exam to get into MBBS, which is the exam to get into to go to med school.
Wow.
And there's about 2,000. Back then there was about 1,500 seats.
Wow.
That's through if you want to go through the All India exam, which is the national exam. And there's other routes now that it's a little different, but back we're talking 2,000. So it was very fortunate to get into. A lot of people don't get in the first time.
Right.
But I'm glad I did.
Absolutely. And is medical school separate? A separate college or schooling like the U.S. where you have undergrad and then you go to medical school, or is it all sort of one program?
It's a one program.
So you start pretty young, like
you do.
18, 19?
17.
17 you start the medical school program.
I was I was maybe 17 and change when I graduated high school, and I was in first year med school.
Can you imagine? Can you imagine 16-year-old U.S. in medical school?
I'm 20 years old. I'm here to help with a procedure today.
Yeah, I was
That's
pretty
crazy.
young during. I think I was one of the youngest guys in med school. I was one of the youngest guys in residency.
Wow.
When I graduated.
So kind of circling back a little bit to what you were talking about when you transitioned over to outpatient care. Can you tell us, for some of our viewers out there that may not know the difference between the kind of medical care you were providing before and what the outpatient medical care is?
So on the inpatient side is when you're ill.
Yeah.
And for example, on the surgical side, if you have appendicitis.
Yeah.
You go into the emergency room and then you get admitted through the hospital.
Yeah.
And in this day and age, most of the inpatient admissions that happen, surgical or non-surgical, are usually admitted by someone called a hospitalist, which is an MD who takes, usually from an internal medicine or family practice background, who does those admissions, manages those patients either themselves or in collaboration with other doctors
in that hospital.
Yeah. And they may or may not, most likely they don't have a history with that patient prior to that admission.
Sure.
And most likely they will not see that patient after that admission.
Right.
Unless there is a lot of times. So for example, we had several patients with chronic illnesses like dialysis or heart disease who would come to the hospital quite frequently, and then you sort of develop a rapport. Yeah. So you see them quite frequently while they're in the hospital.
So that's all inpatient.
Inpatient. So that is the inpatient side of things. And on the outpatient is, if let's say you want to get a pap smear, so that would be an outpatient procedure. You just go to the doctor's office. Or if you have sore throat or any illness that is not life-threatening and not very severe, then you would want to see your doctor. So that's the difference.
Yeah. And so you decided to switch over to that, was mainly just for a change of scenery, or do you felt more compelled?
I think I can do more. It's a circle. Life is a circle, and it's never dynamic, and I don't know where I'm going to be in 5 years. But one thing I do know, the inpatient practice gives you the adrenaline, the ability to deal with extremely stressful situations very quickly.
Yeah.
And I think you take the same skill set and take it to the outpatient world where you're developing relationships with patients.
Yeah.
So, in the outpatient setting, they all eventually become sort of a part of your family.
Right.
So you see them quite frequently, at least 3-4 times a year. And you get to know them, you get to know their families.
Yeah.
You know, a lot of times they know everything about you.
Yeah.
And, you know, you're their psychologist, they are your psychologist. So it's like a back and forth. And, you know, I'm a very personable person, so I like to have connection. So it's like, for me, you know, life and medicine is sort of a parallel. And whatever happens in life, I try to mirror it in medicine and vice versa. So it's like, so for me, relationship building and relationship maintenance and the ability to connect with people, it gives me pure joy. And I think you can accomplish that a whole lot more on the outpatient setting than you can on the inpatient setting.
No, I totally get that completely.
Yeah.
And just to reiterate, your practice right now is called Lakewood Primary Care?
And wellness.
And wellness.
Yes.
Okay, gotcha.
Yeah, so we do, and I think he'll get into a little more logistics of how we, you know, practice, but primarily it's a primary care practice. I train in family medicine. That was my board certification, and then I did, you know, there's a non-ACGME accredited fellowship in anti-aging medicine.
Okay.
So later on in life, after practicing hospitalist for several years, I was going to something called the A-Fest. So you would go to these different parts of the world and connect with like-minded individuals who are, you know, it's between the cusp of wellness, you know, fun, play, party, and also a lot of holistic learning. So it's sort of that kind of an environment. And then I met some people who were doing this, and I decided this was the right strategy for me. It was the next obvious journey in my growth.
Can you describe the holistic perspective, MD versus a DO? I mean, they're trained with the same ideas, but the DO is more holistic in a sense. Like if you have a pain somewhere, they're going to look at the entire body, and they're going to consider all these things. Do MDs practice this as well? This concept, is this how you evolved?
No, it's not. So you know, they both have their strengths, and they both have their challenges in terms of the way the trainings are. So the MD training is more, you know, very scientific, data-driven studies, very pharmaceutical-driven type of practice. And I think the DO practice is a little more holistic. I think I'm not really familiar with their, you know, their program, but I do know there is a lot more emphasis on musculoskeletal and energy.
Got it.
So, but what I do is not necessarily DO stuff. It's, you know, so my bread and butter is still, a lot of it is bread and butter medicine, but I sprinkle it with a lot of holistic stuff, which is, you know, a lot of this, if you think about it, is common sense medicine. So, you know, it's, everyone knows, you know, and it's, you know, diet, exercise is a cliche, but there's, I think it's the single, it's the most important thing, you know, in life. And, you know, our philosophy, because I try to not speak in general things, and I try to be very specific in the way, you know, I advocate to patients and the way I do my charting and the way I think. So, you know, if I see someone, you know, so if I were to just sum up our practice, I would say we like to optimize health in terms of trying to get every person in the best metabolic condition that they're in, optimize their weight, their body composition, and I think that really treats a lot of non-obesity related diseases, conditions. So, you know, people just think the focus is heart disease, diabetes, cholesterol, blood pressure, but you know, the psoriasis goes away. You know, their anxiety goes away.
And it doesn't have to be complicated, does it? Diet and exercise does not have to be very complicated.
It's a discipline thing.
It's a discipline
and most people who have lived life in a non-disciplined way, it's very, very difficult. It's very difficult because food and lack of exercise are great addictions. So if you're sitting on the couch and not working out, it's super addictive because it feels good.
Right.
And it feels good watching Netflix, binging on something
And
for 6
eating-
hours straight.
And eating carbohydrates.
It is
and
not
just-
easy to wake up at 4
Right.
and spend 2 hours in the gym. It's not easy.
Although it's not necessary either.
Yeah.
But what you're saying is intense discipline. You don't have to get up at 4, but
Yeah.
You're talking about principles and living within parameters.
Right.
Having balance.
Having balance.
Yeah.
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 Well, and to that point, because we kind of talked a little bit about this on our last episode, and I had kind of briefly mentioned about optimizing health, and a lot of people are kind of at the opinion that it's, more beneficial to be focusing on exercise. It's more beneficial to be focusing on food. And obviously, it kind of needs to be tailored towards goals and what you're trying to get at. But, for your patients that might be kind of in, less severe situations that you come across, it sounds like you might be inclined to prescribe some more holistic treatments, which includes like, okay, when we say diet, we're not talking about making sure you just avoid pizza,
Right.
but like, you have a stable, healthy balance of like carbs, fats, protein, and
so
healthy forms.
I think usually the way I do it, I practice this on myself and the patients is everything has to be a balance so you can enjoy it. And it should not be punitive. So
Right.
you're going to hate it after 5 days or, 5 months. It needs to be sustainable.
Yeah.
So, those things need to happen.
Right.
There is something to be said about the carrot and stick strategy. So there is something to be said when when you start at a certain weight and you don't know where you're going. You're just lost. You have no idea. And now you've, with different strategies, you've lost, let's say 30 pounds and you feel amazing. And now you are self-motivated.
Yes.
Because you went through hell for the last month or 2 or 3 to
to
lose
that
that 30
point.
pounds, you feel amazing.
Yeah.
And now you want to do more. So I usually take an extreme position on the front end, and then so I can moderate it to the middle
Yeah.
pretty quick,
Yeah.
so that they can get to their end point. And an end point will change. There's
Sure.
never an end point. There is always it's always an
It's a
evolution.
sliding, moving scale.
Yeah, it's always a moving scale, and you always want to. My goal is always that I don't want to see this patient ever again after this year, if possible. That's in their best interest.
Yeah.
I'm a patient advocate. If they stop being my patient for ill reasons and just be my patient for well reasons, great. I would have done my job.
Yeah.
I mean, that's the best thing. The best thing
right
for a
mindset to
physician
have.
is when the patient who is a diabetic, who has all kinds of issues, stops having those.
Yeah.
And they're cured of their illness. That's the ultimate W for me.
Yeah. Yeah.
So that's our philosophy, and that's what we try to do. So we can incorporate different hormone optimization strategies. They work.
Yeah.
Supplements work. Not every supplement, few.
Yeah.
Crash diets don't work, but then certain diets do work.
Yeah.
And then if I always try to keep it to where it's palatable, it's delicious, and low in calorie, low glycemic index.
Yes.
It's just that breaking the cycle usually is a 3 to 6
difficult
month
part.
process.
Yeah.
Because your brain is so addicted to this, the dopamine is real.
Yeah.
And so that's why the drugs come in. And everyone knows about all the drugs that we're using, but we actually are very aggressive. We do more than the GLPs. We do more than just adding the phentermine or the Topamax or the metformins or berberine.
Yeah.
Or cinnamon sticks or apple cider vinegar.
It's funny, a couple of these I've actually used before. I still take a couple of them.
Yeah.
But some of those are natural ones
Yeah.
that can be utilized as a form of GLP-1.
Right.
That I've actually found very, very successful
Yeah.
with. And so, I wholeheartedly agree, at least from my perspective and my experience with that. That's good to hear.
Yeah. So we use, all these strategies. So I'm very aggressive and on the front end to personalize. I'll look at the patient. Yes. If they are, sort of gauge their interest in weight loss. We're just talking weight here.
Right.
Because from what I can see, in our practice, 50% of the patients are overweight one way or the other. And usually just weight by itself is not a problem.
Right.
Unless if they think it's a problem and it's an aesthetic thing.
Right.
For me, it's not a problem at all.
Right.
But when that weight's causing liver function tests to go
Right.
up,
Right.
when it's causing the LDL to go up, the triglycerides to go up, the CRP to go up,
That's your department.
or their blood pressure is now like 137/86 every time.
Right.
There's a problem. It's
Okay.
now their physiological weight has become pathological.
Got it.
So that is you got to fix it.
It's an indicator to do
because
something.
so
Right.
so if you see a lot of physicians, they'll say diet and exercise and give you hydrochlorothiazide or lisinopril or losartan. Yes, that's one way to do it. We don't stop there. I know that the problem here is the weight. We're going to go after the weight.
Got it.
We're going to go full throttle, and my goal is to get those people as close to their, it's not just a BMI thing. Now, BMI, it's more than a BMI. A muscular guy, BMI can be a 29 and totally normal.
Right.
So it's a combination of BMI, percentage body fat, their bones, just looking at them, you can get a pretty good sense of where they're at, where they ought to be. And, there's obviously genetics at play, and there's obviously thyroids at play, and all these other things. But those are less than 5%. The
Okay.
majority of the people who come and say, the problem is the thyroid, or the problem is my dad had this or that. Yes, it could. But most of the pathology happens, due to lifestyle.
And due to the decisions
lifestyle.
you make.
Yeah.
You make
yeah,
personally.
Yeah,
Right.
exactly.
Right.
Exactly.
Okay. And so
Exactly.
when a patient
lack
comes,
of sleep,
Right.
Sleep is pretty
or
important.
lack of sleep, if it's lack of sleep because you're forcing yourself not to
Yeah.
sleep, or if you just can't sleep, that needs to
Yeah.
be addressed.
100%.
So when you see a
100%.
patient, you're looking at all these factors,
Yeah.
and you're saying, okay, this is where
Yeah.
according to all of these things, this is where I believe you should be, you'll be optimized.
Yeah.
And then you work toward that goal.
Yeah.
Awesome.
So
That's
we
good.
do a pretty quick and thorough analysis, and when we examine the patients, just because of the experience over the years, if I were to see the same patient 15 years ago, it would take me an hour to go
Right.
down the list of all the things that I want to know and address. I can usually accomplish the same in a significantly less amount of time.
Right. Right.
And which is good, because now I can get to a decision quickly, and the patient, and I can serve more patients.
Let me ask you this:
So-
we're gonna take
Yeah.
a little turn here.
Yeah.
How has technology, if you're able to answer this,
Uh-huh.
how has technology helped you and your patients get on the same page? Has it? Have you been able to tell a patient, let's do this and do that, and to help you get to that optimal goal that you guys decide upon? Is there something?
Yeah. So
General.
technology is, I think technology used in the right way is an asset.
Right.
And not every patient, especially the elderly patients,
Right.
they have challenges with technology. So you have to, meet the patient where they're at.
So
I think
now-
so.
Mhm.
But on the patients who are tech savvy, we use a lot of telemedicine in my
Okay.
practice.
Right.
We do a lot of that. We use HIPAA compliant texting and HIPAA compliant email exchanges for quick, and we have direct messages on our EMR, like
Okay.
a lot of other practices do.
Right.
We are not different from anyone else.
Right.
But we are different in the sense that we are able to do it in rapid speed, usually within a few hours. So if
Got
there
it.
is a thing, we're able to tackle it, quickly and effectively.
Do you advocate like these watches that give you heart blood pressure and things like that? Are those pretty accurate
so a lot
too?
of patients, they will actually, the patients are smarter than me in that sense, because they
Yeah.
will, they will, especially we have a subset of patients who will send us a tracking
Oh,
data
wow.
from their watches,
Is that right?
and it connects with our EMR, so
Oh, cool.
so there's an interpretation that spits out on our
Amazing.
end. So
It's
we can,
not-
so we can see
Right.
it, with that watch, or I can look at it, but it's more.
Yeah.
It's pretty smart. I think I'm excited where we're heading in terms of tech.
Right.
I think point of care ultrasounds are coming in the future. They're already here, but they will be more mainstream. and more importantly, the education that goes behind it. So that would be sort of a mandatory thing for physicians to be able to detect, diagnose, treat a lot of things while their patient is in the office. And yeah.
So when you have patients come in, of course, with the advent of internet, just generally, and then with AI, they're coming in with a lot of their own ideas. Do you oftentimes
WebMD?
Yeah, WebMD. Did you oftentimes have to convince the patient that, hey, this is just not applicable to you? Do you find that to be a common thing on a daily basis or weekly, or are they seeking your ultimate advice and not really coming with?
No,
I've read this, read
they're
that.
actually pretty honest on the front end, and they will say, they'll say, I went to Dr. Google first.
Dr. Google.
So Dr. Google, and then Dr. Google told me XYZ, and of course, they will preface. And I think that the patients are very smart.
Yeah.
So really, it's really good that the patients are empowered and have a lot of good information.
Right. Yeah.
And that makes, it challenges us.
Right.
And you actually grow as a physician.
Right.
When the patient is asking really good questions, because it forces you to look into things that you normally wouldn't.
Right.
So it's actually, I think, the technology for the patient and all that information that's on the internet, it's made them more aware.
Right.
And it's, the best advocate most of the time for the patient is the patient themselves.
Right.
So if they are going to advocate for themselves, leveraging the technology, it's a good thing for us and for them.
Cool.
So yeah.
So kind of piggybacking off
Yeah.
your last topic a little bit. I mean, in your practice here in Dallas, I mean, what are the most common issues, I guess, or the most common themes amongst patients that you've kind of seen to be an issue currently?
So, because we're in Dallas, North Texas, there's lots of allergies.
Yeah.
Tons of allergies. It usually presents with, a month of coughing, sneezing,
Yeah.
watery
Especially
eyes,
this time of
dry.
year.
Yeah. Especially this time.
Yeah.
So, fall and they said they've had it for a long time, and some of them, they're that bad to where they develop asthma.
Yeah.
Or chronic rhinitis. So there's,
Yeah.
The nose is always running or blocked. So in our practice, we do allergy testing.
Okay.
And we also do immune therapy, so that we give shots.
Yeah.
It's worked out really well. I've actually, matter of fact, I was one of those patients. So I did it on myself several years ago.
All right, I'm all better.
So it worked really well for me.
Yeah.
So I know I can vouch for it firsthand that, that's a great service. That's a good service for the patients.
Good.
We see patients, so there's a lot of female clients who come in, and we have a physician assistant. They usually see her for lots of well-women exams and stuff like that.
Yeah.
In the younger, all across the age groups, we see, lots of obviously seasonal respiratory infections, lots of mental health issues, and we address them, the way appropriately according to their needs. We see a lot of gut issues, and usually the gut issues do not manifest itself in, constipation or diarrhea.
Yeah.
Don't. Yeah, sometimes they do, but a lot of times they will manifest, insomnia, headaches, fatigue, so brain fog, lots of brain fog.
And this is
So
part of
the
the
patients-
holistic approach as well?
Yeah. So I think this is where the paradigm shift, for me, after I did some training and did some more education for myself, is to be able to not put the patients in a box, but put them, in a global perspective. So, you look at the patient, you analyze their social situation, the sleep, the weight, the metabolic condition, job, money, financial stress, and all these things, and then what they put in their mouth, how many times do they poop or not, or so you connect those dots, look at the labs, look at this, the hormones, and then kind of paint a picture fairly quickly, and very comprehensively. And it's not an AI picture; it's more of a picture that's based on my life experience dealing with hundreds of patients over the last couple of decades.
Yeah.
And the feedback is good. The patients have found that they've benefited quite a bit from the strategies that we deploy in the clinic. We also see, like UTIs, pneumonias, patients who have diabetes, hypertension, obviously there's obesity. And then, in men and women, both, hormone optimization after usually about 45, 50. So they will start feeling, it always starts either, if for a female, it's, I don't have the energy for both sexes, actually. I don't have enough energy. I'm not the same I was 10 years ago. For ladies, it's night sweats, just feeling blah, sometimes depression, sometimes anxiety. Even for men, a lot of times low T will present itself with depression. And that's the only symptom. They may have libido, they may have, the other signs that are not suggestive of testosterone deficiency. But really, they're just feeling sad. They said, I felt great, and now something happened. So you have to be diligent and be able to, go to the root cause quickly.
Right.
And before you throw an SSRI or before you put them on something to treat the symptom, go after the main problem.
Right.
And yes, if you are unsuccessful in finding the main problem, they still may need an SSRI, and that's fine.
Right.
There's, symptom treatment is very important.
Right.
But I always believe that treat the symptom and treat the cause. Don't neglect the symptom and don't neglect the cause.
Was this also influenced by your upbringing too, you think, from sort of the Eastern
so
medicine
my mother,
philosophy?
Actually, it's so funny you bring that up. All these things a lot of these things that I learned during my training in integrative medicine. When I was growing up, my mom would practice them on us. She would give us the ginger, the garlic, the honey. She would have all kinds of concoctions. Growing up, I would make fun of it. I didn't think too much about it. I thought it was all foo-foo medicine. But now life has come full circle.
Yeah.
And now I really respect her. And now, sometimes we bounce ideas off of each other.
Oh, cool.
She'll ask me something about stuff and I'll ask her, because wisdom comes with education, wisdom comes with age, and wisdom comes with experience.
Yes.
So the older you get, the wiser you will get if you keep on learning.
Keep on learning and applying those lessons.
If you don't learn, you will lose it. Yeah.
Right.
So that's
So what's the latest? Exercise, latest routines that you're a fan of in terms of getting people towards their optimal
goal,
weights or
so I
other
advocate. Usually, I will say do some kind of a fasting. If I want them to get to, if it's a weight issue. I will often say just skip one meal. Just skip. You don't have to skip the breakfast. If you love eggs, if you love whatever for breakfast, do the breakfast. Skip lunch. Or skip dinner.
Let me ask you a follow up on that. If I'm skipping a meal, I find that I eat more calories the next meal. So how do you get over that?
Fat. You have to eat more fat.
Eat more fat.
More fat. So
I love this part.
What?
So the fat,
you guys are going to educate me on this.
Fat does not make you fat. Fat doesn't make you fat.
You heard it here first, folks.
When you combine fat with carbs, that's
the problem.
How you get fat. Yes.
Okay. What's a healthy fat to eat?
Obviously everyone knows avocados are very healthy.
Okay.
And any kind of fatty meat, even the thigh portion. The breast, I'm not a big fan because I don't like the flavor personally. I like the fatty meats.
Okay.
I like the ribeye.
So eating the fat part of the ribeye is okay?
Oh yeah. Well, you don't have to just the ribeye itself is a fatty portion. So you don't need to be eating the fat off the ribeye.
I see.
And not to cut you off here, but I've always talked about how, and I was mention this again on our last episode about how fats are important for maintaining hormonal balance.
Very important.
And the thing is that a lot of people would think that, oh, well, then that's justifiable to go to In-N-Out and eat, 2
No.
burgers or 3 burgers. And I would say, healthy fats are a major role in maintaining that balance and maintaining metabolism, but also the idea behind it is you're maintaining a good balance of omega-6s and omega-3s. So, having avocados is great, having nuts, having olive oil, salmon and stuff like that.
Right.
If you want to have the animal fats, if you want to eat a burger every once in a while, that's not, that's part of keeping that regimen in balance, so you can enjoy the things that you eat in life, and at the same time get a healthy balance of the healthy stuff that you need to maintain that optimal balance.
Right.
Okay, so I had asked if I skip the lunch.
Yeah.
You said fat, so explain a little bit, extrapolate a little bit. What is that? What were you gonna say
so
there?
what you would do is, add more fat in your coffee, so you can put
Cream
but
oil?
you can get some coconut oil,
Oh,
or you can put some olive oil in your coffee. Have 2
Also-
scoops of that. It'll fill you up.
okay.
So you're not that hungry,
Right,
and it will not add to the body fat in your.
and when we say fill you up,
Yeah.
it's the psychological,
Both.
or physiological that you feel filled up,
No,
but you're
no.
not actually filled
No,
up.
you are filled up.
No, fat has a higher
It's
calorie
more dense.
content.
It's
I
a
see.
more dense caloric
Okay,
content.
so it's not
and it
tricking your
fills you
body.
up.
It's not tricking your body.
Yeah.
Okay, sorry. So you have your coffee, you
Yeah.
have some coconut oil or some. Then what? So
Uh,
then you're saying maybe skip lunch.
Yeah, so I'll say just skip one meal.
Okay.
And I always tell them, if they're trying to lose serious weights, do not eat any nuts.
Really?
In
Yeah,
between.
'cause
Don't have
they're
no
addicting.
snacks. No snacks.
You can eat. I could
Yeah.
eat almonds forever.
Yeah.
They're and you think you're eating something healthy, but they're one of those. I forget
that-
there's a term for it.
It's just
it's like a
you'll
sneaky.
never eat 5 nuts. When
Exactly,
it's there, you're
exactly.
gonna be eating more than that.
Right.
So I often tell them that restrict your food to less than 1 handful. So whatever you eat, try to go with low glycemic index fruits like blueberries or apples, and refrain from eating the melons because
Got
it's
it.
higher. It's higher. The grapes have a lot of sugar.
Right.
The fruit juice is bad.
Right.
It's not good.
I like that. I like that prescription. Blueberries and apples taste better than melons, anyways.
I got it. All right. So then, what would you do for dinner? Again, the handful idea.
Yeah, so usually
Which is
it's
maybe a
it's
pound of
piece,
food, a
piece
couple
of
pound of
some
food.
kind of meat with veggies. I always want a wholesome meal. So, go with the veggie.
Yeah.
Make it a balanced meal. Always try to eat a little less carb than you would.
Okay.
So take the white breads away. Take most of the potatoes away. Take all the good stuff that we love and like, away.
Which is usually white.
Which is very difficult.
usually
Which is
a
very
white color
difficult.
also.
To offset, now you could do more of that if you're exercising hard and heavy.
That's
So
what I was going to
if
ask you.
you are-
It's
all
because
depends
people
on their
justify it all the
lifestyle.
time. Oh, I'm
Yeah.
gonna eat this big pie because I'm gonna work out, or I worked out hard last night, or
Yeah.
tomorrow. Is that justifiable?
It is justifiable
All right.
because it definitely is.
Okay.
Your performance in the gym, if you're really working out hard,
Okay.
or if you're in a Pilates studio or in a yoga studio.
Is it still affecting though your blood vessels and your other your cardio? Isn't it still potentially blocking things? And even though you're exercising.
You mean
You
bad
know,
food is blocking things?
Yeah, so I mean, if I'm justifying eating a whole 5 hamburgers, but I'm gonna work it out later, aren't you still harming yourself? The net is
Well,
still harmful.
I think
or
the
no?
key is balance.
Okay.
You just use your common sense. If
Yeah.
you come up with too many rules,
Yeah.
you will likely
Fail.
you will
Or stop.
you won't even start.
You want to start? Yeah,
And
that's
so you have to make it to where if you're going through a drive-through in McDonald's every day because you love their breakfast sandwich,
true.
okay, and you can't live without it, go after it. Just
Okay.
throw the bread away.
Yeah. Okay.
Throw the bread away. If you're eating, if you're ordering the fries, don't order them. Their fries are not very good.
Right.
It's the wrong kind of oil. They have
Right.
seed oils, which are not healthy.
Okay.
So just sort of tailor your life to your life circumstance.
Right.
So whatever, you can't have perfection. Don't let perfection be the enemy of good.
Right.
So if you're able to get good, get after it.
Right.
If it's good comes easy,
Right.
and perfection is that hard that it's going to stop you from getting there,
Exactly.
don't go after it.
Yeah.
Because whatever
Sense.
good will get you to a great place.
Right.
Because it's like the building block of perfection.
Right.
So you just got to start somewhere, work your way up.
Got it. Makes sense.
So as people kind of progress,
Uh-huh.
now let's say they're kind of at a point where maybe their diet's not optimal, maybe their workout regimen's not exactly ideal, but it's getting them to a place where they start to feel pretty comfortable with themselves. Let's say they're in their like mid 30s or something. And then as they start to age a little bit more, they start to notice genetic factors coming into play, like their testosterone levels are decreasing, your
Right.
estrogen levels are kind of off the charts, things of that nature. You and I were kind of talking a little bit
Yeah.
off camera here earlier about hormone treatments that you prescribe, whether that's, injection, pills, whatnot. And if you can kind of elaborate a little more on what those treatments are, maybe on the testosterone side, on the estrogen side, or maybe just in terms of, hormones in general.
Yeah. So I'll briefly speak to my approach to hormone replacement therapy. I think a lot of men and women, they will know when their hormones are declining, and they usually come with sort of a similar type of symptoms, which are usually brain fog, lack of energy, lack of drive, anxiety, insomnia, and in females it's perimenopausal, postmenopausal type of symptoms.
Yeah.
And they can usually, I see in men about 40 plus, and females about the same.
Yeah.
40, 45, 50. So my approach is, my first question is, what are we trying to achieve here? Are we trying to get to a number on the testosterone level or the progesterone level or estrogen? Or are we treating the symptom? Is there children that are in the picture, or do we need to make children? So the fertility is a big question. That's the first question.
Yeah.
So if they are not if they're not done having a family, and they're still in the stage where they have to create more children, and in that situation, I will always, I will never recommend testosterone.
Yeah.
For men or women.
Like TRT.
So TRT will not be a recommendation.
Yeah.
In that situation, we will first repeat the testosterone levels in 3 to 6 months, and give them advice as to how to naturally raise the testosterone. And I've seen good results. I had a couple of guys whose levels were in the 400 or 500s, and after 2-3 months of great sleep, lots of squats, lots of clean living, a little bit of supplements like zinc, and there's some other natural testosterone raising boosters that you can get on Amazon, actually. Their levels went to 700. And I think an optimal level for a male is anywhere between 600 to 800. I think you do any in that range, it works really well for. And yes, if you look at the books, it will be all across the board. It would be anywhere between 350. If you go to LabCorp or Quest, they'll say 350 is normal. Yeah, it's normal. It's normal for some. Some people have no symptoms at 350.
Yeah.
And some people have a lot of symptoms at 500.
Yeah.
And when you optimize the testosterone to 800, they feel great.
Yeah.
They feel great.
And just to clarify, when you're talking about those levels here, you're talking about nanograms per deciliter, which is a measurement they use, whether in blood test or other various forms they take to determine where your optimal level is.
That is correct.
And men, like you said earlier, typically are optimal between the 600 to 800 range, but they can actually be okay if they're a little higher than that or a little lower.
Right.
Okay.
And that's the total testosterone, and then you have to consider the free testosterone. And then there's sex hormone binding globulin. There's a different types of things.
Yeah.
I will test them for pituitary issues or sarcoidosis or hemochromatosis if I see a 25-year-old with a really low T.
Yeah.
That tells me that's not normal. A 25-year-old should not have a low T. That means there may be a systemic disease which needs investigation. So you can't blame aging for all kinds of low testosterone.
Sure.
So that's where the difference is. You go to some other guy who did a low T clinic. Yeah. It's a one-trick pony. Yeah. So it's just give T to everyone.
Let's put you right on the TRT and get you revved up.
Yeah. So for us, if you're still in the childbearing stage or you want to create more children, we advocate for HCG or gonadotropin injections, which HCG, human chorionic gonadotropin.
Gotcha.
So it's a subcute injection every 5 days. It comes in a vial, self-injected. It stimulates your own testicles to produce testosterone.
Naturally.
So you're not having any issues with loss of your own testosterone,
Yeah.
shrinkage of testicles, and supraphysiological levels. So you
Yeah.
will not. So it will. We have great results on that. Patients can raise their testosterone levels by 200, 300, 400 points.
Yeah.
And I've seen that,
That's
and
remarkable.
they feel, it works really well. And even we'll have some patients who are, 50, 60, 70-year-old who want to preserve the testicle size. They want to preserve their some things that comes with, not taking testosterone
Yeah.
externally. So they would want to get on HCG instead of the testosterone injections.
Yeah.
So now, but if someone wants to go on testosterone injections, we're all about it. We do a lot of pellets in our clinic, which is a procedure that we put it under the subcute space, usually 800 to 1,000 milligram testosterone, which is it's a time release. So it goes over,
Release.
it usually lasts about 5 months. It's for patients who don't want to self-inject.
And
If
the
they have
effects
someone,
are the same.
yeah, so
Similar.
it will. The only downside, the first 2 weeks, you'll see a supraphysiological level because the body is absorbing it, and then it'll sort of plateau.
Yeah.
We have a lot of repeat customers who come back. They love it, both men and women. So the pellets, I like pellets. We do it a lot. The patients love it, but then there's a lot of patients who are totally fine with self-injected testosterone. We monitor their levels, and we monitor their CBC, PSA, the things that we should, make sure nothing bad's happening, their liver function, etc. And in the last year or so, we've had oral testosterone, like Jatenzo. There's a newish type of medicine with the insurance coverage is not very good. So we've had to do prior authorizations for that, but then you take, 4 pills a day. Instead of taking the shot, you just have to take 4 pills a day.
Amazing.
And it will bypass the liver, it will go into your bloodstream, and it will do exactly what a testosterone does. So you don't have to shoot yourself.
So maybe in the future with more clinical trials around it, and with the insurance jumping on, it'd be something you could consider. In clinical research, they've been investigating oral vaccinations for a long time, and they quite haven't got it there, but there's been a lot of money and R&D on that. And plus you can, not to go into a separate topic, but you can transport those worldwide, instead of having these vials that have to refrigerated, et cetera.
No, that's what I have a client who likes to do the oral testosterone because he's a sales by profession, and he has to carry the injections and TSA, etc.
Of course.
So it becomes a little bit of a hassle. With the pills, it's much easier.
Right.
So we'll do that for men and for ladies. We usually the levels, the optimal level is between 50 to 100 on the testosterone, and the estrogen. So we'll check their hormone levels to see if they're low, and if they are, usually the pellet, my formula is about 25 milligrams of estradiol, which is estrogen, with 100 of testosterone, and that's a pellet. It's a pellet formulation because the cream gets really messy, and a lot of patients don't like it, and they love the pellet. So the pellet is, it's good for females who want hormone optimization. We can do the progesterone in pellet form as well, but I prefer the oral. The oral, just because progesterone can sometimes have side effects, and if it's a pellet, it's there you're committed to it for 5 months. But if it's a pill, you can stop it.
Right, exactly.
So,
or missed doses. Right.
So that's the strategy for females.
So for women, in terms of measuring their estrogen levels, what is the ideal amount? Do they measure it in the same way they do in testosterone?
Yeah, but it's cyclical, and it's it's a combination of symptoms and labs.
Yeah.
So always ask them. So my question is, when was your last period?
Yeah.
Let's assume that someone who she's 48 years old, and then the last period was 6 months ago.
Okay.
And then you do the levels, and they're the testosterone is less than 1.
Yeah.
Estrogen is maybe 15, 12, 15.
Okay.
And then the progesterone is somewhere in the middle. So we assume at this point that if the periods are irregular, there are symptoms, that I think we can treat it.
Yeah.
And sometimes before we commit them to pellet, we'll try the cream and the pill and the patch, the estrogen patch, just to test it out, see if there's significant improvement in all the symptoms.
Because of if it's efficacy, or just because patients tend to prefer it more than the cream?
The pellet? Are you
Yeah.
talking about?
Yeah.
Yeah, because it's one and done, right?
Yeah.
You're done for 5 months.
Yeah.
Now, if you go the other route, you're doing a transdermal patch
Yeah.
for estrogen or a cream, then there's a separate cream for testosterone because you're not injecting in females.
Right.
And then there's a pill for progesterone. So do you?
So it's a whole more ordeal.
It's a lot more involved, and you have to do it every day.
Yeah. Okay.
You know,
That makes sense. My mother was doing the cream
exactly,
for a while.
and so a lot of patients don't want to go through that hassle.
Yeah.
It's just a lot.
Right.
So the pellet is consistent. I think it works really great in female. And then we also, are using more and more of peptides these days.
Okay.
So I am using more of the peptides like Simorlin and Ipamorlin, BPC 157, CJC. And these are, some of them like Simorlin and Ipamorlin are growth hormone agonist, meaning they're peptides that stimulate your pituitary gland to release the growth hormone. So they're injected in the evening between usually 6 and 8 p.m. Monday through Friday, and it's a cycle. You do it for about 2 months or 3 months. And then you get off of it, and then maybe you do it again in 6 months.
And what effects will people see?
So increase in growth hormone. So I'm just referring to these particular peptides.
Okay.
So when there is increase in the growth hormone, the side effect will be sometimes you'll have edema, so swelling of your feet. Not a lot. I have not seen too much of it. But the good things are you will, if you're working out, you'll put on a lot more muscle, and the recovery times are fantastic.
Got it.
This is from, this is to treat somebody who wants to optimize their gym performance. But then there is a lot of patients who are recovering from injuries. So in injury recovery, it helps, the peptides will help expedite the recovery on the injuries. So we use that. I would say it just depends on, because it sometimes gets a little expensive. So if the patients want to spend the money, but we have access to all the compounding pharmacies.
Oh, good.
That will deliver these products to their house. They were great. You can use the HCG with the Simorlin or the Ipamorlin. There's a protocol, and I have had patients just, have great results with it.
Fantastic.
I think there's a laundry list of peptides. There is about 20, 30, 50 that are currently in market that are being used for different, anything from anti-aging to gut health, to brain health, to muscle, different things. So I think it's interesting to see where we're heading and which direction we go in with the peptides. But I think it will definitely, open up a whole new treatment modality for the patients.
Kind of, again, piggybacking off your comments about the peptides a little bit, we talked a little bit off camera also about BPC 157, and I see one of the few that I actually recognize when you mention, and it seems like it's becoming more commercially available now.
It is.
Mostly in, it sounds like in pill form because it's distributable.
Right.
But you were also saying that you can actually inject it. And a couple of these other peptides. So
all of these peptides that I was alluding to are
Yeah.
injectable.
Okay.
And some of them now you can get it on Amazon. I don't have much experience with the orals.
Yeah.
My sense is that the injectables work better.
Right.
Because they will bypass any kind of digestion and they will be in your bloodstream quicker. The injectables are easy because it's an insulin syringe and it's sub-Q. So it's not an intramuscular.
Okay.
They're easy to inject. You just have to find a provider who is experienced in dealing with these.
Injections.
Yeah.
And what would be the cadence with which they'd have to get these injections to be effective?
Usually it would be, there's a cycle for about 90 days, 60 to 90 days, and 5 days a week.
Okay.
So it's a very
So it's
small quantity.
Yeah.
So it's usually 0.1 ml to 0.2 ml.
Okay.
On
So these people are coming in regularly.
no, they're just self-injecting.
Oh, they're self-injecting.
Self-injecting.
Okay. All
So
right.
self-injections. the pharmacy delivers, and it comes with instructions, and the patient's self.
That's great.
Yeah, and if they have any issues, we're always, someone's always on the other side of the phone, 24/7, always answer.
Yeah. I mean, what little I had read about it,
Yeah.
because I mean, I've looked at gut issues. I've had some not severe but minor ones from time to time. Because I do a lot of high intensity and training and stuff. And what I had heard about BBC 157 when it came on the scene was that a lot of these people that were in the fitness industry were suggesting it. They were taking it in pill format. I didn't even know they did the injection ones. But it was really good in terms of like gut motility, getting blood flow to kind of maybe your digestive area, and especially if you're someone that might have a little extra weight in that area, that might be preventing that. And so I've always been curious to know, like, aside from the gut and muscular enhancement, or I should say probably more like flourishment, what would be some other good side effects or reasons people should be looking into it
For
any of these peptides?
Oh, for the peptides? Yeah, so usually so a lot of times patients will have insomnia.
Yeah.
And one of the side effects of this medicine makes you sleepy.
Okay.
So I will so let's say if I see a patient who has mild depression, can't sleep, doesn't want to go to the gym because they feel lazy. Yeah. So I will put them on this medicine and do it for about a month or so. Yeah. And you'll be surprised. You'll see results in about 3 weeks or so. Yeah. And 50, 60, 70% of the patients, they will start having some sort of a positive response.
Just feeling like themselves a little bit more.
Yeah, it really does.
Yeah.
And then the other place we use this is for libido.
Okay.
There is, in elderly and even in young, all ages across the board, patients come to us or any provider because of lack of libido. Yeah. It's a lot of times the providers will be dismissive because it's an uncomfortable topic. Yeah. And they really don't have too many strategies to deal with it.
Right. Yeah.
We take it head on, and I will be very specific. We have no problems in prescribing off-label stuff for libido. So we will, treat them with arginine, nitrous oxide type of stimulants to increase the blood flow, or if they need to be on sildenafil or Cialis, or patients are pretty smart. They usually have already tried those things. Yeah. And usually there's different components to arousal. Libido is a very big deal because the Viagra and the Cialis will not treat the libido. Yeah. So you have to actually go on the hormone level, the oxytocin. Yeah. Or you have to use some agonists to stimulate the oxytocin. There's different products that we use. Yeah. Or NO2 stimulants.
Okay.
Or
I've heard of NO2.
Or now peptides. So when you do the peptides with the HCG. Yeah. Great results.
Wow.
Great results. That's wild. Great results for, in the whole realm of everything from arousal, everything from libido, the ability to enjoy with your partner. Yeah. And these are underappreciated things. For the patient, it's a huge deal. Yeah. It's a huge deal. They'll come to you with, they'll beat around the bush, but some patients, they're just very direct.
And so when you were saying like off-brand or like off-market, some of these prescriptions are not really FDA approved. They're more like
a lot of them are not. Yeah, a lot of them. So a lot of them are not. They are FDA cleared. Yeah. A lot of them are not FDA approved, and I think a part of that is, obviously they need to be regulated well. Yeah. But I think there's a financial component. Yeah. To that from big pharma. Yeah. And absolutely. I think that there's that. Everybody knows. Mm-hmm. So I don't have to
talk on another episode.
They actually took a lot of these peptides away from the market a few years ago, but I think they're coming back again.
Wow.
So
that's wild. So looking forward to talking more about that soon.
Yeah. So Raj, thanks again for coming on. Do you have any final thoughts for this session, and then also how can people reach you?
Yeah. So our email, actually, can you cut that? Yeah. The website is Lakewood Primary Care Wellness, and if they go on our website, they can make online appointments, or they can call our office. We're by White Rock Lake, right next to the lake. Next year we will be moving to Presbyterian Hospital, so closer on Walnut Hill and Greenville. I encourage the patients to try us, and before you buy us, you should try us. We are very good in what we do. There's a lot of experience that has gone behind this clinic, and a lot of times I come up with these protocols, and I've tested it on, over the years I've probably seen 100,000 patients. So these are, even though the outpatient medicine is new, but I bring a very unique perspective by combining the inpatient side, the outpatient side, the functional medicine side, the holistic side, and just life in general.
Right.
And I'm a big believer in self-help, self-development. So there's that component. Reading the patients and meeting them, partnering with them, in every possible way, accommodating them, treating them like family. So relationships are everything to me, and that's our core principle for our offices. Be respectful to the patient, treat them like family, create long-term bonding relationship, and they will send their mother, fathers, children to us, because that's how we. Money is not the driver. Yes, the money is important. Business aspect to medicine is very important. Just like any business will fail if there is no money. But I think that is not the core principle, and that should never be the core principle. You should always be the patient advocate.
Amen.
So we will, we do a lot of hormone replacements, a lot of obesity medicine, lots of holistic strategies for autoimmune diseases, strategies to cure diabetes, hypertension, holistic strategies in partnership with the oncologists for metastatic malignancies. So we will, and in the future, we do a little bit of aesthetics. I use a fair bit of PRP in our practice. Matter of fact, I've injected PRP on myself in different joints and different ligament injuries, and it's fantastic. I mean, it works great. It's better than steroids, better than surgery. So if you have some sort of partial tears, we are significantly cheaper than going to an orthopod or a different service place. And we are big believers, for that. So, like I was saying, in the future, we will be going more we'll have a second branch into the aesthetic portion of medicine. Currently, it's just Botox and a little bit of filler and some PRP aesthetically, but we are going to be doing that more in the future.
Well, we can't wait to have you on again, Dr. Kohli, and thanks again for being with us today. So thanks for joining us with the show, and everyone have a great day.
Thank you.
See you next
Thank you.
time.
Next time.
Thanks, guys.